Welcome to the Global Health Network Ghana webinar, and we're speaking on the emergency medicine section. So this is the emergency medicine community of practice, and this morning we're very excited to be having a webinar on navigating the frontline, the crucial role of emergency medicine in advancing clinical research. We have a wonderful panel here to be able to speak today. But as we move on, we would actually like to acknowledge all the groups that have made this possible. So the Global Health and Infectious Disease Research Group from the Kumasi Center for Collaborative Research in Tropical Medicine, the African Federation for Emergency Medicine, and the Emergency Medicine Society of Ghana, all coming together to make this webinar possible. And this is being hosted by the TGHN, which is the Global Health Network Ghana platform. So happy to have you all here. And as we said before, we want to know who is here and who is in our room. So it will be nice for you to pop into the chat room and say your name, tell us where you're coming from, tell us what you do, so that you'll be able to connect and network with the rest of your colleagues online. Without wasting any more time, I'd like to start by welcoming all of you to this platform. A few housekeeping rules, and this webinar is being recorded and will be shared on the Global Health Network platform. Due to the number of participants, you already noticed that your camera and your microphone will be disabled when you come in. Please use the chat feature for the introductions and to report any technical challenges that you are having. If you have any questions as we move along, use the Q&A feature to post your questions, and you can actually even post a question anonymously if you wanted to do that. So as much as possible, we'll try to answer the Q&A questions that come along, the ones that we can answer easily by text. And also, we will invite our speakers to be able to respond to the Q&A questions live at the end of the webinar. So these are our housekeeping rules for today. And we'd like to move on. My name is Dr. Joseph Boni. I'm an emergency medicine specialist at the Comfort North Teaching Hospital and the community of practice lead for emergency medicine for the Global Health Network in Ghana. I'm also a research fellow at the Global Health and Infectious Disease Research Group at KCCR. I will be joined today by a highly experienced panel. The first lecture will be by Dr. who is the head of department of the Comfort North Teaching Hospital in Kumasi, running the biggest emergency department in West Africa. Dr. Lauren Laikin, who is the CEO of the African Federation for Emergency Medicine and a senior lecturer in the Division of Emergency Medicine at the University of Cape Town in South Africa. And last but not the least, Dr. Park Abnoforsin, an emergency physician, and is currently the technical director of Japaigo Prize. With this, we'd like to move in and have some messages from our team members that made this possible. I would like to start by inviting Dr. John Amuesi, who will speak to us about the Global Health and Infectious Disease Research Group, and also speak to us about the group that we're in. Today, joining us, and before Dr. Amuesi comes on, today joining us, we have people from varied countries. We have 368 people that are registered with Ghana, taking about 100 of this, and people from all over the world, including participants from Rwanda, Pakistan, the United States, Tanzania, Ethiopia, Cameroon, Italy, Spain, South Africa, United Kingdom, Uganda, India, Nigeria, Kenya. This is very exciting. We hope we can continue to increase these numbers. So kindly share on your platforms if you realize your colleagues are not here, not to miss out on the Christmas version of our webinar, Navigating the Frontline, the Crucial Role of Emergency Medicine in Advancing Clinical Research. So I'd like to move on and have our first introductory message from Dr. John Amuesi, who will be be joining us live for the opening remarks. This will be followed by some opening remarks from Dr. Daniel Osei-Kwame.
Yes, a very good morning to everyone. It's a huge pleasure to be able to come to you. I'll just take a few minutes to introduce the group that is hosting the TGHN Ghana and activities which are under the auspices of the wider TGHN Africa and the wider TGHN, and I'm sure there'll be more information on that moving forward. My name is John Amwesi, and I lead the Global Health and Infectious Diseases Research Group, among others. This group is a multidisciplinary group of very passionate and enthusiastic researchers. And we do all kinds of research, largely biomedical research in infectious diseases, although some of our work does also foray into non-communicable diseases. We have projects that range from field epidemiologic studies through to clinical studies in health facilities, through to sero studies, which involve field work and involve lab work to the highest of standards. And we also run a couple of drug and vaccine clinical trials. So you'd realize that it's a fairly wide array of research topics that we pursue. One of the research works that we're currently doing in hospital is an ICU registry. And this we are doing in the emergency department at Comfort Noche Teaching Hospital in Kumasi, at where Joe works and Chris also is leads. And then we also have the Ofinsu Hospital where Pak Obina is also working. We're extending this also to, and by the way, we also do this in the ICU at Comfort Noche. And we're looking at expanding this to the Kolebu Teaching Hospital and the St. Francis Xavier Hospital in Asinfosu, and hopefully extending this registry in both ERs and in ICUs to other countries in Africa in collaboration with the Critical Care Africa, Stroke Critical Care Asia network. So that being said, within this context, as I mentioned, the group hosts the TGHN Ghana Country Center, where we focus on enhancing health improvement through research, also try to create an enabling environment where research becomes an integral part of what we're doing, where we build team capabilities and improve just not only our ability to conduct research, but also to collaborate and pool on our collective strength to be able to do more and to see our research being translated into actions which would ultimately improve health outcomes and improve the lot of people in the country, on the continent, and globally. I will stop here and once again also welcome you from my end. I know it's going to be an exciting webinar given the array of speakers and also the array of participants. It's really exciting and we're looking forward to more of these. Thank you very much, and Joe, back to you.
Thank you so much, John, and thank you so much. So Dr. John Amwesi is a senior lecturer and the head of Department of Global Health Department at the School of Public Health, KNUST, and he's also the lead for the Global Health and Infectious Disease Research Group at the Kumasi Center for Collaborative Research in Tropical Medicine, and this is where the TGHN Ghana is being hosted. Without wasting any more time, I would like to invite Dr. Daniel Osei-Kwame, who would give us just a few words on what the Emergency Medicine Society of Ghana is and what they do.
Good morning, everybody, and welcome to this webinar. I'm the president of Emergency Medicine Society of Ghana, a body that brings alongside all emergency practitioners in Ghana, from EMTs to emergency physicians, as well as emergency nurses, We were established somewhere in 2019, and then we've been at the forefront of emergency practice in Ghana and leading the advocacy of emergency practice since. Emergency Medicine of Ghana, Society of Ghana is proud to be associated with the Global Health Network Ghana webinar, which seeks to address the crucial role of emergency medicine in advancing clinical research. This is a course that we are proud to be associated with because it seeks to break down the various rules by which EM can be not only advocates, but actually influence clinical care practice. And then when you look at the fact that emergency medicine is at the forefront of all clinical care, it stands to reason that it is important that we decide and affirm the rule by which we can influence clinical care, since we see almost every patient at the doorstep of our hospitals. So we are happy to be with Global Health Network Ghana today, and then we are glad that everybody is joined, and we are anticipating a very good webinar. We believe that it's going to be a success, and we believe that together with MSOC and Global Health Network Ghana, we'll be able to promote the emergency practice and clinical care of emergency medicine beyond the borders of the cities of Ghana into the hinterlands. Thank you, and you are all invited to this webinar. We hope you have a lovely day.
Thank you so much, Dr. Daniel Osei Kwame, for that wonderful message. Also, we are supported by the African Federation for Emergency Medicine, which leads the advocacy, training, and research work across the African continent. And we're using this platform to invite you to our conference, which is coming up in November 2024 in Botswana. We're looking forward to all of you on this call joining us for this webinar. So without wasting any more time, would like to quickly zoom in to our first lecture. Our first lecture will be by Dr. Chris Opong. Dr. Chris Opong will be speaking on the layering of research over clinical care. Layering research over clinical care. So Dr. Chris Opong is a fellow from the Ghana College of Physicians and Surgeons and one of the pioneers of emergency medicine in Ghana. He is currently the head of department of the emergency medicine department at Komfo Teaching Hospital, which serves as the biggest training center for emergency care in West Africa and the biggest emergency center in West Africa. He also leads a lot of research projects and has been instrumental in ensuring that emergency care is promoted across the African continent and has been a beacon and one of the shining stars of emergency care on the continent. He has been working extensively on the Akiso project, which he will tell us a little more about as we move ahead, and has led a lot of training programs as a lecturer with the School of Nursing at the Kumasi University here, which is a Kwame Nkrumah University of Science and Technology. So the floor is yours, Dr. Chris Opong.
Thank you very much, Joe Bonnie. Good morning, everyone. Good afternoon, wherever you are too, anyway. All right. So I'm going to speak on laying research on clinical care. And I'm excited about this because the kind of environment that we work in, if you are not prompted or if you are not encouraged, it is unlikely that you would think that even research would be possible in such an environment. But I'm here to show you that it is possible. So this will be my outline. So I'll talk a bit about emergency medicine in Ghana and also the role of emergency medicine in our society. Then emergency medicine research, and I will give some few examples on some collaborations that we are having in our directorate. So emergency medicine started not too long ago in Ghana. It started around 2009, where we had a collaboration between some partners from the US and also some Ghanaian partners. And basically, they had to assist us to establish a new residency and also a specialty, let me put it that way. So eventually in 2012, our first group of emergency physicians graduated. and they just did not graduate. We had a residency training at the Confirmatory Teaching Hospital under the Ghana College of Physicians and Surgeons. So from that time, now we have an organized way of attending to emergencies at the Confirmatory Teaching Hospital. We used to see emergencies anyway, but when we talk about emergency medicine, it's all about organizing your approach to seeing critically ill or injured patients. So still, people are not so familiar with emergency medicine since it's a relatively new specialty. So what do we do? All emergency coming through, we are required to acutely evaluate and stabilize all of them, whether they are critically ill or injured. And when we are able to stabilize them, a lot of times we hand them over to some subspecialties or specialties. But a lot of times too, we just see and discharge the patients on our own. We have a unique rule of providing 24-hour services. Some specialties, you might not find them when you need them 24 hours. But emergency medicine is supposed to ensure that 24/7, there's always a competent physician who will be there to attend to emergencies. We work very, very closely with the other specialists and subspecialties because after stabilizing the patients, a lot of them has to be followed up. So these specialists or specialties take over from us when the need be. So basically, we try as emergency physicians to maintain or maintain organization in a busy, chaotic emergency department. Those of us who have been to emergency departments, I think the story is the same even throughout the world. It's always busy and a bit chaotic, but our role is to ensure that there's some sanity in the chaos. So emergency medicine, I say, or a lot of people who agree with me, will be a window on the society. Why am I saying that? A lot of times, patients will be coming in for different reasons. But some will be coming in because of environmental hazards, drug use, disease outbreaks. And it's easily a way that you can detect societal problems. You realize that we see no discrimination. Any patient, whoever walks in through our door, we are required to take care of them. And because of our unique role, we see all kinds of cases. So this makes emergency medicine a very important component of the public health system. I have this example of this early detection of disease outbreaks, for example. I remember one day I was working on a shift, and a triage nurse approached me and gave me the information that a lot of medical students have been coming in for the past 2 days with fever, and I think we were treating them for malaria. But she believes something is not right. So she brought 2 of them to me and I had to take care of them. Then I realized that it might not just be malaria. So I interrogated them, managed to get in touch with other students who had been there. And we had to quickly mobilize, get, I think KCCR, those of you who know KCCR, is one of our research institutions at the university, to come and screen them. And we were able to detect that it was an H3N2 outbreak. So if we are organized, that's one advantage that you can have. You can easily pick societal problems, disease outbreaks, COVID. So when COVID came, it was the same issue. Anytime there's a spike, it's the emergency unit that can easily tell that this is what is happening. So it means that this is a real fertile ground for research, because everybody is coming in and very, very important trends would probably be passing right in front of our noses. But it's a very, very high pressure environment with limited resources almost all the time and diverse patient needs. So it poses a little bit of a challenge when you want to do research. You have problems with time-sensitive treatment. There are times that you're not so sure of your diagnosis. You might not have your diagnosis. At times, you might have to deal with patients who cannot afford diagnostics, especially in our part of the world. And if you are combining this, I want to put it as maybe chaos with research. I believe there's a little bit of a challenge, but we are supposed to be reminded that we have a unique role that provides evidence, that can provide evidence-based solutions that can improve clinical care and patient outcomes. And at the right time, I'll share some of the experiences. So there are some key research areas that is common with emergency medicine departments. Triage, for instance, most organized emergency departments will have the patients being triaged in order to determine the acuity of the patient that are coming in so that we give them timely care. And that gives an avenue for a lot of triage research that will help improve how we prioritize management of our patients in and out of the hospital. So we also have to deal with diagnostics. Anytime you have to deal with a patient at the emergency unit, you need to know what is wrong with them. And a lot of times we are fertile ground for doing research when it comes to rapid diagnosis that can help us make timely decisions. So, well, everybody is coming to the emergency unit, so treatment interventions is a very good opportunity to test new drugs, procedures, and technologies. And I will share one experience that we had in our department later on. So quality improvement is also very crucial in patient care. And I think one of the places where you are more likely to probably commit an error will be the emergency unit where there's a lot of chaos. But with the quality improvement research, we're able to minimize waiting times, minimize errors, and so on and so forth. So it's also one of the areas where emergency medicine research is quite prominent. So there are several methodologies that we're able to use in our environment, though we have some constraints. And observational studies is quite common because and easier in our environment. We're able to easily identify trends. We can, talking about trauma, talking about every disease, anytime there's a trend, the emergency department is a very easy environment to identify trends because all the patients are coming through that door. Well, we are still able to do randomized controlled trials in such an environment, and also qualitative research where we want to understand the patient's experiences and perspective when it comes to clinical care. There are several ethical considerations in our environment, that is the emergency department. And I wouldn't say so much about it because one of my colleagues will be going deep into it. But I think the main ethical dilemma is balancing research with clinical care. So how do you prioritize your patients who needs care, and at the same time you want to get some information from them as well? So I think one of my colleagues will also deliberate on it. Looking at the future of emergency medicine research, I think is probably going to undergo some transformation. And in this age of personalized medicines, I think it will be a very good environment for more research in that area. We have a lot of data, and we will have to, with the registries that we have, a lot of information and a lot of information can be gathered that can help us improve prediction and prevention of disease and illness. And we might want to also explore telemedicine and also mobile health to improve access to emergency care. And the famous artificial intelligence machine learning is coming in very quickly. It's already in. And I believe it is something that we'll also have to move into to help us improve our treatment and diagnosis and also decision-making when it comes to patient care. Funding is always an issue when it comes to research, and I believe there are other ways that we can explore to get funding for our research, collaborating with industries, private foundations, government institutions, and so on and so forth. And I believe we are all already exploring all these avenues, but there are other places that we also have to look at so that we can improve funding when it comes to emergency care. So one very important thing that we've been doing at our department is collaboration when it comes to research. And I think it's been very, very helpful because with the scarce resources that we have, I believe what has really helped us is collaborations. And collaborations is just both external and let's say national collaborations as well. We started by establishing a CAT Emergency Medicine Research Office. And this research office has been coordinating all our research activities for us. And I believe it is something that's very, very significant that a lot of people should emulate. The moment you get an office, coordination of the research becomes easier. And we've had a lot of multidisciplinary teams doing research, nurses, research assistants, other healthcare professionals, all collaborating to come up with very good research. Then we also have our international partners and national partners as well, other institutions in country who has partnered with us to help us do a lot of research. So we're also looking at leveraging industry to help advance our research efforts. So I would just want to mention a few of such collaborations that we've been having in our department. We have the AKISO study, which I'll elaborate further. It's a sepsis study looking at the pathogens in an austere environment. We are doing that in partnership with a team called AKISO, which is basically funded by the US military. And we are looking into a lot of stuff. I'll discuss that one. Then we have the Activate study, which we looked at stroke thrombolysis. So we're looking at barriers that we've been having because most of the time our stroke patients don't receive thrombolysis. And we're thinking, and what we normally say is that they don't present early. But we also wanted to look at why they are not presenting early. And we decided to do a study in collaboration with the neurosurgery unit of our hospital. And through that study, we were able to look at the barriers that affect our ability to do through stroke thrombolysis. We also have our ICU registry, which Dr. Amuezi mentioned earlier. Then we also have the trauma registry in our department. And truth be told, when you come to our department, in the midst of the chaos, there's a lot of studies going on. So I want to talk briefly about the AKISO study. So I mentioned that it's an initiative from the US government and administered by the Henry M. Jackson Foundation for the Advancement of Military Medicine. And a very interesting thing happened in 2014. The US military collaborates with the Ghana military, and the Ghana military has a military hospital. So they usually collaborate with the military hospital anytime they are in country. So this time around, somebody hinted them that they should come and have a look at our facility. They were bringing a sepsis study. So the moment they stepped in our facility, I think the reason was that they realized that we were organized. And that is the emphasis that I want to make. You have to be organized in the midst of the chaos. So they, instead of going to the military hospital, which was where they usually do their studies, they decided to select our site. And that wasn't even intention, that was just a coincidence. And that goes to say a lot that the emergency department is a very conducive environment for clinical research. So with this research, we are looking at they are looking at host-based biomarkers that is going to help improve sepsis care. And they are coming up with several diagnostics and also guidelines, because they are also looking at improving clinical care, and they are doing a lot of analytics that will help improve patient outcome. And I think this has also helped us a lot, especially with our diagnostic microbiology. They've improved our infrastructure when it comes to diagnostics, microbiology, and all that. And I think it's one of the ways that we are also benefiting from the research we have been embarking on. And we also did another study with them. I think the biosensor study, if you look at the picture on the screen, there's a device on the chest of one of our patients with sepsis, and this biosensor was actually validated. One of the validations was done by us, and is able to monitor patients remotely, checking heart rate, doing telemetry, doing respiratory rate, and the rest. And this has really, this study was done at our place, and this device has really been, the device came in very, very handy during the COVID. So COVID, people couldn't go close to the patients. People were scared and all that. People didn't have PPEs. And I realized that it was being used. I was monitoring it myself. It was being used, especially in the developed countries. And I think it's also one of the devices that we can also use in our, what do you call it, developing countries, especially when we don't have PPEs and the stuff. You can do the monitoring with just a mobile device. Well, you need internet as well. And it's been explored to do a lot of things, like patients who are very sick, but you want them to go home, and you can just leave it on them. And I think when you have it on them, you're able to monitor them remotely through the internet. So Akiso has helped us a lot. We are now, we know, have some way, somehow, we know our microbial burden, and especially antibiotic resistant patterns. I think a lot of our antibiotics that we've been using are facing a lot of resistance, and it's become very clear from the research that we are doing that it's something that we have to be paying attention to. We have to leverage on the research and also take actions. We also getting to know different organisms that we are not familiar with. I think one of the important ones that came up is an organism, Burkholderia pseudomallei, which causes an infection called melioidosis. So what happened? We were able to isolate this organism, and the literature says that it's mainly found in Southeast Asia and also some parts of Australia. But we were able to pick 2 samples in our end, and we decided to do further research by digging soil samples in a place called Nobewam in Ashanti region, where in some rice farms. We exported them to some research centers in the US, and they were able to prove that we actually have Burkholderia pseudomallei in our environment as well, which probably might be causing melioidosis. We need to do further studies to confirm it. So it's it goes a long way to tell us about how important research is and what we can get from it, especially working from our emergency department. So through the stroke study that we also embarked on, the neurology team in our department, we were able to tell that about 12.8% of our stroke patients were actually presenting early, and they qualify for thrombolytic therapy. Initially, we all assumed that most of our patients are not coming early. And because of the findings, we have formed a multidisciplinary stroke team that is aimed at doing stroke thrombolysis, and we hope to start implementing it from January next year. So we just don't do the studies and publish them. We try to implement the findings of the studies as well. So it is quite challenging doing research, and they are the same old problems competing for research dollars. I also put in CDs because now we have to also get CDs as well, the ethical issues. And we also need to bridge the gap between doing the research and just disseminating the information. And recruiting and retaining participants at the emergency units can also be quite challenging. But there are, with that, a lot of experience that we've had in our emergency department, we have ways that we have employed to reduce and to also help us retain a lot of our participants. I remember recently there was a trauma study that one colleague was undertaking, pediatric road traffic accident, and he was complaining that his numbers were too small. And I drew his attention to the fact that, well, a lot of them are discharged from the emergency department. So if you are just going to stay on the wards, you are not going to get all your subjects. So with that experience that we have, we know how to navigate through this complex environment. So in conclusion, emergency medicine plays a crucial role in improving patient outcomes and optimizing healthcare delivery. So by fostering collaborations among researchers, policymakers, we will continue to advance and also ensure high quality care, clinical care for all patients. Thank you very much for listening to me.
Thank you so much, Dr. Chris Opong. That has been so insightful. Looking at the aspects of AI and emergency research, I'm sure that will bring up quite a lot of questions and discussions even after this webinar. But the key point here is to remain organized even in the midst of a busy emergency department in order to be attractive for research to come your way, as it will bring about some total improvements in your care and the quality of care that you provide. And do not just do the work, publish, but make sure you implement this to improve patient care. Wonderful presentation by Dr. Chris Opong. Thank you so much for this, Dr. Opong. We would like to quickly move on to our next speaker. Our next speaker will be speaking about the ethics of research in the emergency department. It's really tricky, where Chris might have hinted on this, but some people will tell you that you cannot do research in the emergency department. They're just too sick. You need to concentrate on getting them better and not be conducting research on such patients. But our next speaker, who is a specialist in emergency medicine and the CEO of the African Federation for Emergency Medicine, Dr. Lauren Lai-Kin, will be speaking to us on this topic. She's also a senior lecturer at the Division of Emergency Medicine at the University of Cape Town in South Africa. Lauren collaborates with government agencies, non-profit organizations, local and other international stakeholders in strengthening emergency care across the Africa continent. Through her work, she's committed and contributed towards the development of regional research capacity and evidence-based strategies to promote equitable, accessible, and sustainable African emergency care systems for Africans by Africans. She leads multiple projects and is in direct touch with the emergency care section of the WHO. And every day we try to improve emergency care across the African continent through the African Federation for Emergency Medicine, where she is the CEO. Without wasting any more time, I would like to give the floor to Lauren. Thank you.
Thanks so very much, Joe. Good afternoon, good morning, good evening to you all. It's an absolute pleasure for me to be here with you. And thank you to Joe and the Global Health Network Ghana for the invitation to speak at this event. I'm going to try and keep this talk brief, as much of the nuance in the subject emerges from what I think is a collective discussion, and I hope that we can explore this together in the Q&A session that follows. All to say that many of the themes in this presentation are a little bit sensitive and difficult to engage with, but I hope to create a safe and respectful space that we can openly discuss the issues and the considerations around global health equity in research. You'll note that I deviated just slightly from the original speaking topic. It is the benefit of leaving your slides to the very last minute and not sharing them with the event coordinators. So I have taken the liberty to shift the discussion just a little bit, but it very much aligns to the ethical principles of research, just on a larger scale and within the global health research landscape. Certainly within this audience, I don't think that there's any need to convince anyone today about the value of emergency care and the need for robust, high-quality emergency care research outputs from the African setting. But it never fails to cause me to pause for a moment each time I look at these heat maps, where we can clearly see that the highest burden of disease is geographically aligned to those low and middle income regions. And we see here that the World Bank disease control priorities has modeled out that 54% of the deaths that occur in low middle income countries each year are from conditions that could be addressed by organized pre-hospital and facility-based emergency care. And so if we start in agreement that the development of emergency care systems may reduce up to half of the deaths and over a third of disability-adjusted life years in LMICs, then it's a natural progression that in order to inform and guide the development of emergency care systems, research that is contextually relevant to the setting in which the healthcare interventions are performed is just essential. As we know, specialty training is an essential component of emergency care system development. Emergency medicine as a formal specialty is one of the newest disciplines in medicine, with South Africa being the first country in sub-Saharan Africa to have an EM specialty training program since 2004. And we see that experts in emergency care in Africa overwhelmingly agreed that research which addresses local priorities and questions is an important driver of the development of the specialty on the continent. Over the period 1999 to 2014, while there was significant growth in the number of studies published by African authors in emergency medicine, most of these studies were observational and focused on undifferentiated complaints, which authors postulated at the time reflected the relatively immature state of African emergency medicine research. It's not been an easy road, and barriers to research identified in a survey of African emergency care professionals were lack of funding, lack of open access literature and subscription fees, lack of formal training, and lack of allocated time for research, as well as lack of publication or open access fees charged by journals for publication. And perhaps as a result of these barriers, it was proposed that African emergency care researchers then tend to frequently co-author papers with authors from other continents, and sadly, even emergency care research in Africa has a lower impact than research from any other geographic area except the Middle East. Since 2004, there are at least 12 other African countries now with emergency medicine residency programs. And as emergency care efforts expand, with that comes the increasing need for context-specific research that translates into evidence-based clinical practice. The Lancet Commission on the Future of Health in Sub-Saharan Africa is an encouraging and critical call to action, urging African leaders to embrace contextually driven evidence-based recommendations and adopt an approach based on people-centered health systems that is adapted to country-specific needs. Because homegrown solutions to sustain improvements in health outcomes is an essential element to safeguarding and future-proofing health in Africa. Developing context-specific research capacity in emergency care across Africa is complex. And so the golden question today is how to approach this with an equitable and an ethical lens, considering the global landscape within which African emergency care research is conducted. And so the question that you might be asking is, what does that global landscape look like? Well, it's that of global health, and perhaps more specifically, global health equity. Global health is a broad and interdisciplinary field focused on improving health and achieving equity in health for all people worldwide. And despite the field's emphasis on equity, a substantial and ever-growing body of literature continues to highlight persistent and pervasive inequities in global health research that mirrors existing power asymmetries between research based in low and middle income countries versus high income countries. Seya Abamola is a Nigerian-born public health specialist who currently serves as the editor of the BMJ Global Health. In his first inaugural editorial as the BMJ editor, he was grappling with the idea of global health and what it means for a respected scientific journal that focuses on just that. He referenced a blog by a former BMJ editor, Richard Smith, who created a tongue-in-cheek definition of global health where we've come from, and where we hope to be. The sentiment is that we've moved past versions 1 and 2 and find ourselves now at Global Health 3.0, which is about people, but people from high-income countries leading health programs in low-middle-income countries. And we're not yet at 4.0, which we hope to see people from low-middle-income countries leading health programs in low-middle-income countries. So why this cynical view? Let's have a look at the Global Health 50-50 analysis. Governing boards represent the locus of power across organizations active in global health, where decisions are made that influence the health outcomes of people around the world. Here we see the extent to which so much of global health is governed by the global north, with 75% of the leadership held by high-income country nationals, only 2.5% held by low-income country nationals, and 1% held by women from low-income countries. Coming back to this slide, we see that 82% of funding bodies are seated within high-income countries. And so the who gets to make the decisions and sit on these boards is still quite unequal. And so what does this mean for emergency care research in Africa? Well, in so much as research should be answering questions that move the needle for those living and working in Africa, those who occupy the leadership positions, for the large part, fails to include low and middle income countries and the global south. The bottom line being that it manifests time and time again in what Pi calls the default settings in global health. And so it's no surprise that this is also reflected in who drives the research agenda, who dominates authorship, and who edits the research. We know, and there may be some of you here today who have had experiences with the global health research agenda being driven largely by international funders based outside of Africa and major global health agencies. Nearly all of these are led or dominated by experts from the global north. More often than not, they set and they drive the research agenda on behalf of people in low and middle income countries. This is taken from an analysis from 2016 to 2020, which found that African authors are inadequately represented in research about African emergency care and health systems, despite the majority of studies in global emergency care taking place in Africa. This graphic represents the location of global emergency care studies included in the analysis, and this is the first author location in the studies included in the same group. And so we're starting to see the trend emerging that each time we try to engage in contextually appropriate, ground level based activities and emergency care, there seems to be this tendency to default to those global health settings. Similarly, we see that during COVID-19, as cases rapidly surged worldwide, so too did medical publications. In a review of African authorship on African papers during the COVID-19 pandemic, African contributions to the global body of evidence during the pandemic remained low. And so while 1.3 billion people, or 17% of the world's population, live in Africa, only 3.9% of articles related to COVID-19 published in the top 10 medical journals was relevant to the continent. And this was an improvement on a 2018 analysis, which showed that although Africa's research sector is growing faster than any other region, it still produces less than 1% of the world's research each year. Here we see Abimbola again contribute to the discourse on the complexity of authorship and dissemination of research outputs in an editorial titled The Foreign Gaze. As important as it is for us to consider who is being included in publications, so too is where the research is being published. Abimbola describes the obligation that LMIC researchers might feel to write for an audience that is different from the population who the work involves and affects. Often, when pushed to choose to publish in a foreign journal over a local one, the foreign journal wins out for reasons being a multi-country study, funders' expectations, the journal's impact factor or for promotion, grants, and prestige. There's certainly an argument to be made for this, where publications originating from a country may advance the cause of global health in that country, but it is unfair and even misleading to pay undue attention to the foreign gaze, because if the academic literature to which we give priority does not reflect that local experts are at the forefront of addressing local problems, then there's something wrong with the literature because it doesn't reflect the reality. And he instead offered an ideal of local people writing about local issues for local audiences. But in order to do this, it's important to focus on enabling community-led participatory approaches and to find context-tailored solutions which promotes the co-creation and continued engagement of research with community stakeholders. At the heart of it all, efforts to address imbalances, whether in authorship, funding, participation, and dissemination, are incomplete without aiming to go beyond the surface and without tackling the attitudes and practices that those imbalances represent. But equally, there's a responsibility in the hands of individual researchers and institutions to ensure appropriate cultural and contextual input in their work. Let's take a moment to look at who edits the research. Editors often act as gatekeepers to the dissemination of research outputs, and in so doing, who edits research matters a lot. In a 2019 study, Pai et al. Examined the diversity and inclusion of the composition of editors and editorial board members of 12 major global health journals. Across all journals, if we focus in here on the images in groups 2 and 3, a third of the editors were female, and a third were based in low middle income countries. When combined, 1 in 10 editors were based in low and middle income countries. And among the 12 journals, all except 2 were managed by institutions in the US or Europe. However, what we see now emerging is an encouraging step towards allyship, certainly on the part of some journals. Journals like BMJ Global Health, Lancet Global Health, and PLOS Global Health have acknowledged the need for equity in board representation as a component of decolonizing academia in low and middle income settings, and they've pledged to achieve parity in gender and representation of low middle income country expertise. And a little closer to home, the African Journal of Emergency Medicine, since its inception in 2011, specifically requires proportional inclusion of African authors on all submissions to be eligible for peer review. And so, where to from here? I wish I had the answer. Don't we all wish we had the answer? Because at our core, I don't think any of us, whether individual, institution, or organization, is intentionally trying to act in an inequitable manner. But despite this being a topic of discussion for a long time, there's still a way to go in identifying actionable steps to rebalance the power differentials. As pragmatists, we seek to find elegant solutions to complex problems, and so we look to checklists, frameworks, and toolkits, all of which have an important role in place. But given the impossibility of achieving equity by overlaying oversimplified solutions onto an inherently inequitable system, with many embedded structural and procedural barriers, there's the possibility that these interventions are insufficient or even potentially counterproductive or harmful. As our knowledge and values in the space have changed, before we move forward with intention, maybe the first step is to stop and acknowledge our position. Talking about concepts of structural power, inequity, and injustice can be difficult, and in order to tackle these discussions with sensitivity and awareness, it's important to highlight our positionalities and to remember that we possess positions of power and privilege, but we also, in times, have been in positions where we've lacked power and privilege. And so as a starting point, we should then consider first stating the position and perspective that informs the way in which we choose to communicate and articulate our thoughts. From where I am, I recognize that I'm of Asian heritage. I'm also a third-generation South African, and I represent what's considered a minority in many spaces. I also recognize that I work at an academic institution that is not without its faults, and through my positionality, I acknowledge that my perspective may result in the potential and the likelihood of bias in the way that I have approached this presentation and future discussions. Similarly, the African Federation for Emergency Medicine acknowledges that even as a regional collective, there exists local power differentials and clusters of privilege that facilitate research and publication from a few centers. But the organization has committed to strengthening mechanisms which acknowledge Indigenous perspectives and promote equity and inclusivity in research representation. With this guiding principle and lens in place, AFM has placed a sharp and strategic focus on 3 specific operational areas. One is to continue to expand our journal, the African Journal of Emergency Medicine, now in its 12th year. Additionally, the AFM Research Working Group has developed a 14-part research course to teach emergency health professionals the fundamentals of conducting clinical research. The course aims to address the needs of health professionals in African emergency care and is suited to the context in which they practice. And as we learn from each other, we edit, adapt, and create new iterations of the course so that it's dynamic and an evolving offering. And just last month, we hosted an Equitable Partnerships in Emergency Care in Africa workshop with a view to recentering the African voice. The aim of the workshop was to serve as a launching pad for future conversations and ongoing dialogues around redefining the partnership priorities of emergency care programs across the continent. The intention is to start working on breaking down some of the power differentials that exist in the global EM collaborating space, with a focus on the ideology of power with, not power over. Because if we're ever to achieve sustained progress in moving the default settings in global health in our favor and in favor of the global south, we have to collectively commit to doing so and actively challenge the so-called norms and not rely on those in the global north to do so on our behalf. We're optimistic that this is the start of many other conversations, events, and activities that will follow, with the goal that each AFM member organization will discuss ideas around equity within their own context, and that AFM can support the consolidation of this information with the hope of creating an opportunity to reconnect in person during AFCAM 24 in Gaborone, Botswana in November 2024. I'm going to end there and thank you for your attention. I'm looking forward to engaging with you during the Q&A session, but otherwise, if not, please don't hesitate to reach out to me via email, and I've included my contact details here. Thanks so much for your attention.
Wow, thank you so much, Lauren, for such a wonderful presentation. We couldn't have asked for a better twist to the topic, but to broaden it from just ethics of one research to the global health experience and global equity of research. We're so happy for this. And I know people have some questions on this. Kindly use a Q&A session to put your questions in the chat. We will have a few minutes at the end for us to be able to engage with the question and answer session. Without wasting any more time, I would like to invite our next speaker. So our next speaker, by no doubt, is one of the most reputable emergency physicians here in Ghana. He is currently the technical director for Japaigo Rice in Ghana. He is the head of the emergency center at the St. Patrick's Hospital at Ofinso. He graduated from the School of Medical Sciences in the Kwame Nkrumah University of Science and Technology in Kumasi, holds a master's in public health with health service planning and management, and also further training in the Department of Epidemiology at the School of Public Health at the University of Washington in Seattle. He is a fellow for the Fogate Injury Prevention Program and recently participated in the Global Health Training at the Fogate International Center at the NIH. He is one of the fellows of the Critical Care Registry, which he will be speaking more about, which is with the Oxford Moro group and hosted by the Global Health and Infectious Disease Research Group at KCCR, where he remains a research fellow. His research interests with publications in very high-end journals include alcohol and illicit drug studies, injury prevention, pediatric trauma, brain injury, health applications in emergency care. He has been working under the guidance of Dr. Giorgio Drill, who is one of the leaders in emergency care in Africa, and a research team through the Emergency Medicine Research Office for decades, where he co-founded to make this happen. He is removing all doubts on the platform by stating he is happily married with 3 children, and he is a very exciting and focused leader and a wonderful mentor. And without wasting any more time, I'd like to invite Dr. Park Singh to give us the next presentation on registries and the role in clinical research and quality care.
Thank you very much, Joe, and a very good afternoon, good morning to everyone. Thank you very much, Joe, once again, and thank you for the opportunity again through the Global Health Network to give this presentation on registries and their role in clinical research and quality of care, especially also looking at it through the eye of the emergency medicine department. I will follow this outline, and I just want to say with this opening statement, and I'm still not sure who said it, but I really like it. I wish I could take us through the whole gamut of how a registry is put together, but let's just say simply that maybe when data about similar diseases, conditions, or treatments are entered into a registry, the information is used by doctors and other medical experts to improve the quality and safety of the care that you and other patients receive now and in the future. And I especially like the point about in the future because we all will potentially be patients one day. We will be tomorrow. And so if we are able to put these together, a registry helps and probably would provide the opportunity to ensure that your care in the future is more tailored and would come with good outcomes. Basically, what is a registry? We would say simply that a database designed to store and analyze information about the occurrence or incidence of a particular disease, some procedures, events, sometimes even devices, medications, for which the inclusion criteria is clearly defined in such a manner that minimizes variability and maximizes precision of inclusion within a specific cohort. Some also think that basically it's simply a computer application used to capture, manage, and provide information on specific disease conditions to support organized care and management of patients with chronic disease. But you'll find that in the emergency department, we deal also with mainly acute diseases. When we talk about registries, what do they do? Strongly provide improved capacity for research. It's one of the platforms that provides and guides data-driven quality improvement projects. And I want to highlight again, as Dr. Boding noted, the excellent work that has been done by the Oxford Murray Group through the critical care registry that is being run at Comfort Teaching Hospital in the emergency department, at the ICU, in the pediatric ICU, and then also at St. Patrick's Hospital, where I work, at our emergency department, where clearly the inputs of the outcomes or the outputs of our critical care registry has guided and provided a platform for QI steps to be taken. I want to highlight, especially in St. Patrick's Hospital, at the height of COVID, when we started our critical care registry, we were able to, for the first time, really map out and see through an overview how our patient care pathway was. And at various points, through audits and meetings with the clinical staff, nurses, doctors, and alike, we sat and looked at how our patterns were, and based on the data, we're able to take significant steps to improve care. Also provides data-driven influence of clinical practice for better disease outcomes generally, just to ensure that patients are doing well. You should have the opportunity to look back, look at your patterns and trends, look at your figures, look at your care outcomes, and then determine among yourselves clinically whether you're going the right way or something is amiss. It helps to improve the standard of healthcare in general. Additionally, it helps healthcare to be more focused on what is important to you. And this is, I'll talk a bit more about the examples of specific clinical registries, you will find that a registry may not necessarily be set out to answer every question, but just clearly detailing a specific problem or question of interest would be the first step to help you answer the questions of interest that you may have. It helps to make informed decisions about healthcare, helps providers find information implanted in medical devices. That's for those who would be running registries that are a bit more medical device focused. And a more sustained way of ensuring that you can keep your clinical research and audits going is by having some repository of a sort that helps you to ensure that you have, for want of a better word, a process in place that guides clinical research and audits in your health institution. I'm just wondering what this may be familiar to a number of people who work in Confanote Teaching Hospital, but just people may be wondering, why did I put this picture here? Well, this is a 40-footer container, and your guess may be good as mine. You can type in the chat what you think may be in this 40-footer container sitting right at the outstep of an outpatient department in one of our tertiary hospitals here in Ghana. Is it just a container so we can post adverts and obituaries? Well, my answer is research is hard. So to your left, you'll find bundles of folders of patients who have been cared for many years. And this is the repository for patient care, patients who are cared for. But you also find that in this repository is also the opportunity for finding a way to map out and follow longitudinally the course of care of your patients. At the same time, for me, this is my prototype registry. Now, we can move all of this into a computer-based, more focused system where we will not have to keep bundles and bundles of folders that are termite infested, but you can actually have this same information in a more organized way that can guide clinical care in the hospital, but at the same time also answer some important research questions. Research is hard, I say, and you can imagine if you have to do some study and you have to spend the whole day in this container, you will be sure to go through quite an experience. So critical care registry, I mean, what we have there, what I showed in the picture there, I mean, is what we have, I mean, and through the guidance and the leadership of Dr. Amoisi and team put together in what is the critical care registry that is running in Confanote Teaching Hospital and St. Patrick Hospital, that over a period of time, basically focusing on patients with critical care needs, we have sought to follow these patients over time, follow their course of care in the emergency department, collect important clinical information on them whilst they spend their patient course in their clinical course in the emergency department, follow their outcomes, look at interventions that are provided them. And really, what I'm just sharing here is just a dashboard that we have from one of our sites. And really, currently, we've been running for a little over 2 years. And I should say that we have currently more than 7,000 to 8,000 patient databases that we have collected, that we are following up on, that we are using as a basis, as I shared in the purpose of clinical registries, to really guide patients' care, importantly, guide quality improvement in the emergency department. And also, this is good substrate for research. Are there clinical registries in Africa? Well, there are quite a number, I should say. And some of these have run in a number of countries, and I would also focus a bit about what is going on in Ghana. But we have the Pan-African Clinical Trials Registry, we have the Sickle Cell Disease Registry that is running in a number of countries. We have the ophthalmic registries in Africa that also looks at ophthalmic pathologies, and that also is in a number of African countries. We have the Africa Cancer Registry Network. This is a very big registry that's focused on cancers, various cancers across Africa. And I know that a number of countries or a number of institutions in various countries actually are partners of this registry and provide data. And that's the beautiful thing about clinical registries, that you can actually get data, and you can actually get data from different places or different institutions collaborating to ensure that we have what it may be a more contextualized and a more generalizable picture of what the interest may be. There's also the African Renal Registry, Africa Cancer Registry, the Africa Cancer Genome Registry, and then this acute heart failure registry is not necessarily African, but this is from another from one of the developing worlds, but I know they also have interconnected networks in other African countries. In Ghana specifically, we know of the famous cancer registry that I won't say started in Confanoche, but I know Confanoche, they've been a key player. I think it may have started there, but we have very useful collaborations from other institutions. The cancer registry has done great work. The sickle cell registry that I talked about is here in Ghana. There's a childhood cancer registry, and then of course for the these are all parts of the African cancer registry I talked about. There's also the prostate cancer registry. Interestingly, we also have our critical care registry that Dr. Amoesi referenced, and then I have also spoken a bit about. And then, of course, in emergency medicine, we have the emergency medicine department. Dr. Chris Opon talked about the trauma registry, and then the emergency medicine research office also started what was an electronic repository. Basically, we decided that can we move the 40-footer container with a number of folders that are termite infested, start organizing them into disease processes of interest and collect them longitudinally. And so these are things that are available, and I know other African countries also have these collaborations, and indeed registries. We have a number of registries also in the Western world as well. Question here is, do you want to start a clinical registry? Well, if you are interested, or it's something that's doable, it is not too hard, but it just takes a bit of determination and focus. Articulate the purpose of the registry. It's important to be clear. And here, you want to be clear so that you do not just collect information that is not of use. And indeed, a registry is not the same as an electronic health record system, as we have here in Ghana and other countries where all our clinical care of patients is computer-based through an electronic database platform. It is not necessarily the same as a registry. A registry must have a clear purpose. You must determine if a registry is an appropriate means to achieve that purpose. You need to think through this with other stakeholders, identify important stakeholders who will play that role. And these are steps we actually took when we're putting together the critical care registry here in Ghana. Engaging key stakeholders, ensuring that key stakeholders are part of the process, understand what we're trying to do, ensuring that engaging key stakeholders, apart from helping to improve participation and collaboration, also helps to take away the chances that you may be duplicative of what others are doing. And then clearly you look at accessing the feasibility and sustainability of the registry within your clinical space. Now, then if you are able to answer these questions and able to follow these steps, you are on a good course to start a registry. And the next phase is planning for a registry. You need to build a registry team. I dare say that you may not be able to do this all by yourself. Of course, it depends on the amount of work you have and the amount of volume of data you're looking at, but clearly getting a team of people who are there and available to help, people with different competencies and skill sets who would all play a role to ensure that the running of the registry is successful, because you will find that running a registry is something that is continuous. And for us as clinicians, there are times when our clinical work will take us away, there are times when family will take you away, there are times when other important priorities will come in. You will need a team that would be on standby to support you in this way. Establish a governance and oversight plan. This is also important. And I think that Lauren has also has spoken to this about governance and oversight plan. And in this also comes the issue of ethics and ensuring equity. Define the scope and rigor needed. Clearly, I would advise a narrow scope. I would advise being very specific and being smart about the scope that you want to focus on as far as your registry is. Otherwise, you would keep going and going to a point where you find that, well, you have huge data sets, interesting, but really it does not help you to answer any question. Define the data set, patient outcomes that you're looking for, target population, clearly defined where your start point for collecting your data and where clearly your endpoint will be. For us in the clinical care registry, one of the things we're doing is focusing on patient outcomes within the critical care spaces of the hospital. And so you will find that we may not collect data from outpatient department because it is not within our target population and our scope. And then, of course, you would need to go through a study plan or protocol and go through the necessary ethics, and then you are on your way to develop a project plan. I wish time were available to really go through the various steps, but if you are able to really navigate these paths, you are sure to be on the way to really get a registry started. Of course, you would need somebody who is skilled in developing a computer database. You would need some support from a biostatistician. You may need some support from people who have some epidemiology background, but clearly, and of course, your clinicians would also be important here. And of course, you would also need trained and dedicated research assistants who would support you to collect data. These can all be managed within a reasonable resource limits based on what your scope is all about. And I heard Chris talk about funding, and I'm sure that funding also comes in here. I want us to think about the importance of registry or the utility of clinical registries in LMICs, but really looking at it through the public health eye. And here, Dr. Christopon has mentioned the fact that it helps to reduce exposure to risk factors for diseases. Why? Because we pick up these disease patterns through our care processes, through the patterns we see in the data that we collect. Helps to strengthen early detection and management to reduce morbidity and mortality, strengthen health systems for prevention and control, which is really important because we have found increasingly, and research is showing that the emergency department is one key area where disease outbreaks may present. And so having a focused registry that follows and looks at patient trends and patient outcomes may be one of your very first steps to picking up disease processes, and also one of the very first places where prevention and control could be initiated. Of course, helps to strengthen multi-sectoral collaboration for prevention and control because our findings and our outcomes will trigger processes through the public health network, and that helps in disease control. And of course, your findings would be interesting for funders and donors, and this may probably be one of the ways where you are able to attract funding to sustain the work that you do. Registries are not without challenges. Registries, one of the key things, as I've noted, because of usually the narrowed scope of registries, they are found to be quite independent of each other. And so you will find that even in places in the same institution, there may be different registries answering different questions. It's a challenge in itself, but also think of, if you think of it conversely, a registry that answers every question really is not a registry, and it becomes difficult to manage. Of course, these are mainly successful registries that run on computers and run on special networks, and these can come with a bit of finance and resource challenges. And of course, you also need some technical eye to support in case of technical challenges. One of the things we also have found in registries is that over time, you have a lot of information that you can use, and clearly the opportunity to use the findings and information and to share that sometimes becomes limited. And this is also one of the ways, one of the things to cure this is to really open up and open up to collaborations, open up to clinical registries that are similar in other settings, just so that information from your place would be merged with other places to sort of bring up useful information that is cross-cutting. But often we find that registries are a little limited, and there's just very little information that is data that is analyzed and little sharing that is done out of these. Because sometimes there are challenges of non-standardized data capturing systems for registry. And this often comes about when it is not properly planned, when you do not really set a clear focus and look at data sets of interest. Sometimes we just start registries because we want to have registries without really clear focus. And after a while, you find that your data capturing tools are not standardized, and so you're not really answering the questions that you set out for. That being said, there really still is an excellent opportunity in having clinical registries in a hospital setting, especially in the emergency department, because they offer us an opportunity to really have an eye and to answer questions of interest. And as I noted, public health, or those who policy makers are interested in trends. They are interested in what the outcomes have been. They are interested in answering the question, where do I have to put my money in? And sometimes you would find that your clinical registries can answer those questions. The way forward is to really find ways to harmonize various registries. I'm saying this, it's not easy to do, but it is worth considering. But I also think that one of the very key steps, and that's what we have with the critical care registry that we have through the Global Health Network under the leadership of Dr. Amoesi, that we have the opportunity to collaborate with other critical care registries in other countries, and really having that global data set gives you some strong harmonization and collaboration. It would be useful to consider running registries as part of a national system. And I know that Ghana, we are going towards this gradually. In other countries, like in the UK, through the NHS system, they have clear registries that are run through the national system. And this really is also strong because you have national backing, you have a number of collaborating institutions being part of this, and your data is wholesome and stronger. Collaborate with other sectors of relevance to use data from the registry. I've noted that, and I've noted how we are doing this strongly through the critical care registry. And then, of course, increasingly, as we perfect the act of having clinical registries, we would have to work towards standardized data capturing tools that would really ensure that the answers to questions that we are looking for are clear and specific and are collected appropriately. Thank you very much, and I'll be happy to take any questions if there are.
Thank you so much, Dr. Pakobna, for saying that was an amazing presentation, overlaying what registries can do. And I like the way we moved from a metal container through to repositories, through to well-fledged registries. And now we have registries that are using AI to be able to spot quality improvements and then report these out to people. Wonderful presentations out there. One key point I got from this is that aim at collecting small good data and not big bad data. Do not dump your entire electronic medical records onto your registry and without being able to curate and get the thing out of. An important point to note was also harmonizing the registry. So how do you standardize the forms that we use in Ghana, Uganda, UK, South Africa, USA, so that this data can link across to each person, and inferences can easily be made as we populate these registries. I'd like to thank all of you for such a wonderful presentation. It has been so insightful. Appreciation to Dr. Chris Opong for his presentation on overlaying research in the emergency department, and also to Dr. Lauren Laikin, who looked at the research aspects and focusing more on the global health research and health equity, and then Dr. Pakobna Forsen, who looked at how registries can support in the development of emergency care research. At this point, I would be happy to take questions from the House. You can put your question in the Q&A session, and we will be happy to read it out. So I have two questions here, and I will be happy to post it to any of our panelists. So thank you for a wonderful presentation, Dr. Chris Opong. This question is, how do you achieve the balance between integrating emergency medicine with clinical research to address immediate interventions, whilst also ensuring that primary care and preventive health measures are not sidelined. So Chris, this question is for you.
Thank you, Dr. Bonnie. Emmanuel, yes, I understand your question, but is a bit of a difficult balance. But I think from experience, one thing I learned is that anytime you are doing research, let's say in an emergency department, you might not want to be on duty, and getting some what do you call it, experiences from the Akiso project. I remember that those times when you are on duty and you attempt to also do the research alongside, and you run into challenges. So get a clearly dedicated team, the research assistants and the clinician on the research project should not be working, probably on leave or something. And it helps a lot. Otherwise, there's going to be a lot of ethical issues and also a lot of challenges that you might have to deal with. And yes, so that's what I want to say. I hope I've answered your question.
Thank you very much, Dr. Christophe. I also want to throw in that the research and emergency departments will not interfere with your emergency care. And those are always the preambles where it will state that these patients or these people can only be, you can only speak to them, interview them, collect the data if it does not interrupt with care. But on the angle of how do we ensure that primary care and preventive measures are not sidelined? Dr. Forson, what do you think about this?
Yes, Dr. Bonnie, I was just going to touch on that, and Emmanuel, thank you for your question. So I would want to put out here that you will find that emergency medicine and emergency medicine research, especially, provides a clear background for promoting primary healthcare, as well as also it's the outcomes of the research actually provide basis for preventive health. And I'll explain this in this way. Usually we think we contextualize emergency medicine or emergencies or accident and emergency centers as the place where patients with acute care needs are. But also we have found increasingly that it also is the place where people actually seek primary healthcare needs. You will find that people of course, people stray and find their way. And of course, emergency medicine also helps to guide them to where they appropriately need care. And so we have that mix of people who come with acute illness, people who come with chronic care needs, but we also have people who also find that place as their first point of call. You will even find this in other developing places where it is difficult to really get an appointment to see a GP or to see your family practice doctor. And so they would use the ER as a place where they come to get primary healthcare needs. And so really, one of the things that emergency medicine, emergency clinical research provides is the outcomes of these actually enrich and guide primary healthcare processes. The outcomes of our research that is done also really provides a basis for improving preventive health, because for us in emergency medicine, preventive health actually reduces the risk of having emergencies and reduces the outcomes that we have, often the bad outcomes that occur in the emergency department. And so you will find that emergency medicine or the emergency medicine research has become integrative over time to ensure that we answer some primary healthcare needs and then also provide and promote preventive health as far as the outcomes and the learnings from our research findings are concerned. And so we really integrate it in a very nice way. And I have examples to give where, in the emergency medicine research department in Kopanochi, we carried out the HIV study and found outcomes of patients who are presenting with HIV. Did other studies where we found people with diabetic needs and looked at how the attendance to the primary healthcare clinics was concerned. And this study was actually at the emergency department, but you found that our findings really were integrated and actually linked to what goes on in the primary healthcare and outpatient departments. Thank you.
And thank you very much, Pa, for that brilliant answer. And it ties in how emergency medicine remains the middle of all the healthcare, both aiming at advancing all the way to critical care and operative care, but also at the front end of preventive care and primary care. And our next question from Julius. Julius is happy about the webinar, and he says, my concern is that he has not heard much about pre-hospital emergencies and is looking for when we can have more inclusive discussions on this. Lauren, I think we had mentioned quite a little bit about pre-hospital and how emergency care covers all of this, but I would like you to expand on this. What do you think?
Thanks, Joe. And Julius, I think that's a great question, and it's a question that really should be posed in as many forums and in as many platforms like this as possible. So please do continue to ask these questions. I think it really is important for us to advocate for the various professional cadres that are working within emergency care, whether that be in the pre-hospital space, the nursing space, and not just a physician-led, and not have it just be a physician-led discussion. I say this with the disclaimer that I am a physician-trained EM person, but in the roles within which we fulfill within AFEM, we certainly appreciate that emergency care is a spectrum. It is a system that requires input from all aspects, whether that is from the pre-hospital to the in-facility domain, in order for there to be robust development and strengthening of emergency care systems. That being said, I 100% agree with you that when it comes to representation, there's not nearly enough representation and voices at the table that showcase and share the perspectives of other professional cadres. And while I am a proud physician, I am not always proud to say that physicians are very good at speaking on behalf of others, which shouldn't be the case now that emergency care is evolving, maturing, and developing on the continent. Certainly, we also know that emergency care is largely not provided by physicians, and oftentimes the backbone is from nursing colleagues, from community driven initiatives, and from pre-hospital providers. And for that reason, in order for us to move the research agenda for contextualized emergency care in Africa, we have to be mindful and deliberate to include all of these categories and providers in the discussion. It's not an easy task, it's not an easy undertaking, but within AFEM, I would encourage you to reach out to us to see how you can become more involved. I'd love to have your input. One of the ways that we ensure that there is multi-professional intersectoral collaboration is that we have a specific out-of-hospital emergency care committee, and within our various activities, we are agnostic to professional cadre. That means that any of our activities and any of our resources are co-created and targeted for a diverse range of emergency care provider. And for that reason, you'll see that much of our language around the work that we do is centered around emergency care and not emergency medicine, because there is that bias towards physician-led activities by labeling it emergency medicine. I hope that that is helpful, but it is an ongoing discussion that we are having, and I'd love to invite you into that discussion with us. Thanks.
All right, thank you very much, Lauren, for this. And I think that the healthcare should never be seen in silos, but as a continuum of care, looking at pre-hospital, looking at primary care through to pre-hospital, through to emergency care, critical care, operative care, all the way to rehabilitation. I don't think any part of these conversations can be left out. We, however, will focus on emergency care, as this is the emergency care community of practice. So, Julia, thank you for this. You might have just suggested the next topic for our webinars, and I know that we have our coordinators, Dr. Hazel Hartford and Lewis, on the call. So we might be looking at our next webinar from the emergency care community of practice, looking specifically at pre-hospital care and we'll be excited to have your inputs on getting this done. For our last question, I will throw this back to Dr. Forson. How do you promote collaboration among researchers to establish research registries in a region where the norm is solo research for self-promotion?
Thank you very much, Dr. Bodi. Yeah, I like that question. Rakshinda asking about a region where research is a solo self-promotion. I think that, yes, indeed, it appears that many places probably have had that solo campaigns as the starting point. But I think that it has been, what has worked has been the increasing recognition that research cannot be done in silos anymore. No one person can do an exciting and all-encompassing research. And you will find increasingly that over time, I mean, over the past 30 to 40 years, scientific articles and journals that are I mean, many journals, we've moved from that landscape of one person as the author and increasingly have found people supporting as co-authors. We've gone beyond that into having people of different cadre actually also being involved in clinical research. So I think that really the first step is fostering that environment where research is shared openly. Sometimes people do things in silos because they don't know what others are doing. They do not know that somebody else next door has an interest in this. And so one of these platforms, and I really want to congratulate the Global Health Network for providing this background, because we get to share what we are doing. Somebody hears that, oh, we are doing this and they are doing that. And really that recognition often serves as the opportunity to start to collaborate. Of course, when it comes to collaboration, there's clearly a storming phase where people's solo interest and self-promotion desires would come in. But often that rocky storm settles, and you will find that people get to recognize the impact of doing things together. I want to talk about the critical care registry as a point where we have emergency physicians, we have intensivists and critical care specialists, we have people who have infectious disease backgrounds, we have epidemiologists, we have all coming in to really support. And you find that this blend of cadre really makes the difference in the shared interest and in the goals that we have. And so I think that the first stage is really having these platforms where research can be shared, people can talk about what they're doing openly. And then also, I think the other thing is the transparency in running such registries, because you will find that we've gone through various phases, and as Lorraine noted, how in the past involving in clinical research was an imported good where some team of experts will come in country and then they'll come and work with you, and then they'll go back home, and then before you notice, they have published 1,000 papers without your name showing up anywhere. And then over time, one person's name will come up to me. So we have gone through that trajectory, that openness and transparency of what interests there are in supporting each other to really build each other's capacity. And I want to also note the support we received through Dr. Moesi and team in the critical care fellowship that we were involved in. It really provided a background to harness and to build your skills. No interest, just to ensure that everybody is developed and that every person's skill can support in the common good of building research in the region. I think that these are the quick thoughts, but it's hard, but it's not impossible. We've gone through that process here in Ghana, and I think increasingly we are seeing some growth, and I believe that this can be done in other jurisdictions as well. Thank you, Anova.
Thank you very much, Dr. Forson. It's hard, but it's not impossible for us to be able to bring this collaboration together. I did put a link in the chat room for anybody who is interested in linking up with a critical care registry to complete the form, and it will have the team reach out to them on how we can expand not only within Ghana but also across the African continent. There are two more statements here, and I'm being mindful of time, so I'll quickly zoom through the two. And one of it is that, do you think that the path for research in the region begins in country or should be simulated from the region? Dr. Lauren, I would like you to take this briefly to speak about this. The path of research, should it be regional based or should it be country based?
Thanks, Joe, and thanks for another excellent question. I think this is something that we grapple with often as a regional organization that represents interests of a diverse range of teams and professional societies, and all within different spaces in emergency care development. Certainly, we appreciate that the diversity and the needs for emergency care on the continent are too diverse to simply have one discussion at a regional level. So I think, to answer your question, it very much depends. It depends on what the discussion is focused on and what the objective is of the discussion. If it can, with regards to, something like setting research priorities, that is very much something that is seated within the local setting. And so each country or each team should be looking at the research priorities that speak to the development areas, the priority areas, the strategic areas that they have identified. Because while there might be overlap and alignment, certainly priorities in one setting cannot be applied to a different setting in a different stage of emergency care system development. However, we know that there is strength in having collective discussions, that there is unity in coming together to create a collective voice. And for the purposes of learning from one another and collating resources, as well as mentorship and collaborations, there is intense strength in being able to do that. We also know that within Africa, there is a very strong sense of community, which is unique to the way in which we approach the work that we do. And so we need to embrace that, we need to harness it, and we need to leverage that in the ways in which we develop our research work and support each other in that research work. It's kind of a discussion that we probably need to set aside a lot longer to talk about, but I hope that roughly covers the ideas around working together as a regional collective and a collective voice, but still being able to pursue country-specific priorities.
Thank you very much, Lauren, for that comprehensive answer. And with this, we would like to conclude our webinar. I saw a message that popped up about how do we integrate emergency care into facilities that do not have emergency care yet. I think the channels continue to remain open to promote emergency care across all fields. But in the chat room now, I have posted one of the simplest ways of incorporating emergency care into your facilities, and with that will come emergency care research. So the basic emergency care course is available, open resource online. You can jump onto this or contact us behind the scenes on how we can help bring this to your hospital, to your institution, to your facility, to start emergency care in that space. Also, our residency programs across the African continent that you can reach out and get more information on. With this, I would like to thank our speakers, most importantly, starting off with Dr. Chris Opong, who is emergency medicine specialist, head of department from the Komfo Teaching Hospital, Dr. Lauren Lai-Kim, the CEO of the African Federation for Emergency Medicine, and an emergency medicine specialist in Cape Town, South Africa, and Dr. Park Obnaforsen, an emergency medicine specialist and currently technical director for Jopaigo Rice Project. My name is Dr. Joseph Boni, and I have been your moderator. I am the president of the African Federation for Emergency Medicine, and I would like to thank all of you for being here with us and all our partners, the Global Health Network Ghana, for the tremendous efforts put into this, the Global Health and Infectious Disease Research Group, and with our coordinator, Dr. Hazel Hatsford, and the lead for the group, Dr. John Amwesi, the African Federation for Emergency Medicine, and the Emergency Medicine Society of Ghana. But most importantly, you for staying on with us for this great webinar. We wish you happy holidays, a prosperous new year, and we will come back to you multiple times to have you join us for more deliberative discussions. Thank you all and have a wonderful day. Bye-bye.